Today, what I'd like to review is using the digital technology, specifically Invisalign, in what I do, the ClinCheck, in setting up my perforation cases, accelerated cases, and how I can actually increase the predictability of my aligner outcome. So this is part 3 of our series that we've been going on. And doctors, those of you who have not met me yet, I am in Laguna Hills, California. I currently practice in the office. I've done a little bit just under 1,000 cases. I'm been an Invisalign provider for about 10 years now. And the beauty of it is I get to not only teach it, I get to work it, I get to see new products in the orthodontic community when it comes to clear aligner treatment. And as a general practitioner, I'm always proud to present cases of us understanding how we can always give the better product, better outcomes, and most obviously for us to have a technology that's behind us. In my case that I'm going to be talking and discussing is the Invisalign processes, as well as the accelerated tooth movement that comes along with some osteoperforations that we've been discussing in the past. So reviewing of today is answering some of the questions that doctors have been asking me. Is the process safe? Is it something that I can benefit from? I'll just do a quick little review. Those doctors who have not yet engaged in Propel or in perforations in the practices, understanding that we're using the patient's own biology. We're not injecting anything. We are actually helping the osteoperforation in accelerating tooth movement. And by that means we get to work on the bone and change the aligners quicker and faster. Whether you're Invisalign provider, wire and bracket provider, or other clear aligner treatments, there's always some sort of a downtime of that 2-week intervals or changing the wires in that 6-week time period. Now we get to accelerate it and change our timelines, since the bone itself is what we're working on. So small little mechanics, if those of you who remember the inflammatory process that is required for tooth movements, is specifically cytokine activity. So doctors, those of you who've heard me say this before, this might bore you, but we've got to review a little bit of how is it possible that I don't get any root resorption? How is it possible that I'm about to move these teeth faster and quicker? Because it doesn't make sense to me. Well, very quickly, understanding that what is needed in tooth movement is the inflammatory process that triggers the cytokine activity. And a lot of research, a lot of science in showing as you start to put pressure and force on the tooth, you need the bone to move with it, and that osteoclastic and osteoblastic movement needs to be accelerated, and the osteocytes proliferate faster, and you create that inflammatory process in terms of cytokine, which is needed to get the bone growth and, if you will, that activity to get that force of movement. Why? If the bone is like concrete and you put a lot of force, you can get root resorption. And so it's not just necessarily about the activity that we're creating, but that momentum, that force creates inflammation. Bone starts to remodel, osteoclastic, osteoblastic activity happens, and the tooth starts to move. By us creating a small perforation, by us creating that inflammatory process using the Propel product, now we get to increase that cytokine activity and the bone remodeling, and now you can change the aligners faster. So just a quick little review in you doctors understanding how this is working. It's not just necessarily by adding greater force, but rather creating that momentum of tooth movement by creating a cellular expeditious movements. Now, Propel itself, a company which is not only science driven, but they've had award-winning technologies. Propel has been an innovator, at least in my practice, when it comes to orthodontic product lines, and the best of class winners. And I'm very happy and very excited to have this integrated in my orthodontic treatments and tooth movements. There's 3 different drivers that are currently in the market with Propel. One is obviously doctor controlled. You don't have to worry about patient compliance. This is very easy. You have the accelerator RT, which is a disposable tip, and the accelerator PT, which is the newest electronic, if you will, a automated device that allows the spinning of the head into the perforations. So we're not really manually doing it. I'll be showing you videos of all these and the procedure itself as for review. There is an informed consent that I have. It's also on the site that you can go download on the Ataii.com site. Some doctors like to infiltrate. Some doctors like to use the profound topical. I do rinse with the chlorhexidine rinse before and after. This is just to make sure that there's no debris or the tooth is actually without any kind of I know that infection, we always deal with tooth extractions. We never do a chlorhexidine rinse, but it's also to keep a nice sterile area. And I set the device on whether it's 3 millimeters, 5 millimeters, or 7 millimeters to just perforate the bone. We're not going through and through. We're not putting it on top of the root, but rather in between the roots. And its inter-root is where we're putting in, and we're twisting the device into the bone and bring it right back. Anteriors typically are 3 millimeters and posteriors about 5. I've yet to do 7 millimeters into the bone yet. Haven't had bone that dense, but all of this is to create that cellular activity, cytokine activity, by its inflammatory process and keeping the osteoblastic, osteoclastic at a rapid movement, so the tooth, as you put the torque on it or as you change the tray, the tooth starts to move in that position, allowing the bone to be less dense for the time period of anywhere between 3 months to about 4 months. That's how long the cytokine activity lasts. So therefore, typically you need one device per patient per treatment. Some contraindications would be patients who are obviously pregnant, some ASA patients, type 3s who are systemically compromised or immune compromised, or patients that are on steroid treatment. I'd like to add the bisphosphonates and the Sally Field drug that I've always mentioned before. So obviously these would be the contraindications as a review for those of you doctors who are now performing but are expanding the perforation world in terms of which patients can I do in the treatment on and which could I not. Now, those of you who are looking at this perforation depth, anteriors, as I said, 3 millimeters good, 5 on posteriors, depending on the density of bone, and the ClinCheck software does not show us the bone density, and even there's a disclaimer that says the gums are basically not a real true indication of the patient's gum line, but we do know the enamel and gingival juncture, where I would like to tell a lot of doctors, keep it at the 3 millimeters for now. If you've got very dense bone or tori that you're trying to hit on the lingual parts, I know some orthos are hitting the linguals. I don't. I currently keep it buccal to the teeth. I'm not doing any lingual perforations just yet, and it's just predominantly because I've gotten great results with just doing the buccal. I don't do really extreme crazy cases, and as you can see, whether they're a class 1, a crowding or spacing or rotational case, these types of cases, as you've seen me talk about before, are some of the cases that our patients don't want to wait longer, 9 to 11 to 12 months or 13 months to get done. So it's a really office builder for me to have the perforations done, looking at the ClinCheck. And just a quick little review, when you look at your ClinCheck software, and we're going to go detailed into the ClinCheck software, as I see now there's about 60 of you logging on. It started from 30. So you look at the ClinCheck software, I'm going to show you the different angles I look at the ClinCheck and where the perforations would be ideal based on what tooth movements. When you see a lower arch and you see the rotation on axial movements, well, that would mean what? I want to do minimal IPR, and there's going to be collision, and I want the bone to cooperate. So that way, as I start to lingualize the upper arch, as I start to close, as you understand, lower crowding, upper spacing, teeth sometimes hit each other, sometimes we get posterior open bites. We're going to discuss all of that throughout the webinar. I just want to give you a glimpse of how we can identify on the ClinCheck software the difficult tooth movements and where do we actually see them. So I'll show you some tools as far as seeing the movements and where the perforations would be ideal, whether I put on the premolar or molar, and where are some of the locations of difficult movements that we need to release and challenging movements we need to release. So as you can still see the ClinCheck software as I'm showing you here, I like the overjet view on a lot of patients, and we're going to talk a lot about looking at these different types of accelerator, or whether it's a manual method. And those of you who've seen me kind of do this in 3 twists, and that's pretty much it, into the bone, and I pull right back. Very simple. This is done with an accelerator. It has a little light, LED light with it. It's one of the earlier versions versus the power driver. The power driver on the bottom of your screen. It's much easier for me to go in with the power driver now. Not as much work on my wrist. And I just pull right back, and it's a disposable tip. So all of these are to create that inflammatory cytokine activity, which we're going to discuss. But where do we perforate? How do we know, and what does it look like? And those of you doctors, and I know a few office managers that are on the line today, in discussing with your patients, it's very simple. I show you here what it looks like initial when the patient walks out. Looks like little bee stings. A week later, where you see areas that have small little bruising area, nothing major. And by week 2, you've completely closed off, and just like any other cut or areas that you've done a deep cleaning on, you go back to normal. But the cytokine activity lasts 3 to 4 months. So you're going to have this inflammatory process, and the rapid cellular activity lasts you for almost half, if not longer, on the teeth, because you're changing the aligners faster now. Whether you're changing it 3 days, 5 days, or 7 days. And right now, currently, I'm at 5-day intervals in my office. I was doing them at 7, and now I'm seeing it is tracking beautifully. So I'm at 5-day intervals. I get to finish these cases faster. Okay, so let's go ahead and talk about the ClinCheck software and how we can actually plan in using the 3D controls, as well as where do we create the perforation. So doctors, there are 2 key considerations using the ClinCheck software. I use it as a diagnostic tool. I can also use it as a treatment tool. And really, that's what we're doing. We're looking at the features that are given to us from a diagnostic perspective. We actually have access to midlines, tooth size proportions, gingival heights of contour. We get to actually see the occlusion, contact points, if you will, the buccal corridors. We can see the black triangles in the gingival area of the teeth, axial angles of the crowns. We can actually see the labial angles of the crown angulations, as well as the intercuspation, how they come together. What I like best is from the posterior view, or the back of the neck of the patient, if you will, back of their head. I get to see how it looks from the posterior view, including the curvus V and the overjet and the arch form. These are the diagnostic tools, and I show you this because on the ClinCheck Pro, I'm going to go through a couple of different tool settings that might help you in seeing these different angles and make a little bit more sense, because the useful tools in everyday use for me in the ClinCheck is the grid feature. And those of you who are well aware of how Invisalign works, you know the superimpose of where the teeth were and where they're going to be moving to, as well as the occlusal contacts. We're going to talk a little bit about occlusion and how the bite sits. And the photo tab is invaluable for me, because I get to see what was the patient looking like, how did the smile line look like, so I get to actually utilize that. And these are my everyday tools that I go to. But we're going to go deeper with this. We're going to go deeper a little bit about some tools that doctors you may not know of, and those of you who have been using the treatment movement assessment form. As you can see right there in the treatment section, you can simply just click on that, and it shows you the difficult movements, whether these movements are in a blue colored or moderate movement or advanced movement. Automatically it's given to you as to which movements are predictable, as well as the tool section. I want you to pay attention to this. If you do a drop-down menu on the tool section, you can actually not only see these challenging movements, but I get to actually put a quantitative value to these. So I get that they're advanced, but what does that mean? Does it mean that's greater than 2 millimeters, more than 4 millimeters movement? What's the rotation? Well, in your tool section, as I mentioned, you can actually activate the difficulty, where it's activating movement difficulty tooth, so you can actually show the movements, and it actually activates which teeth are the most difficult movements, and it puts a big old blue circle. In this particular case, if you look at the tooth initially, I thought my difficult teeth movements would have been number 8 and potentially number 10. But the reality is number 9 and number 10 are a lot more difficult. And by activating that difficulty movement tool, you actually see that the extrusion is about 2.5, just about 3 millimeters of extrusion needed. On that lateral, that's a challenging movement. And whether or not we're going to get that, the ClinCheck software is telling you, look, this is a difficult movement. So without Propel, or without any kind of working on the biomechanics of the bone, these two teeth are going to be a hard teeth to move in. And it's good to use that tool setting because I get to actually see it. And most importantly, I get to take away from the guessing work where if you see the two little red dots, that's just me superimposing where I thought I would want to do the Propel perforation, which is on number 7. But the reality is I'm going to not only need it on 7, but I probably need it on 8, 9, and 10 because already it's telling me 10 and 9 are difficult. And Dr. Ataii, there's a 2.5 space that you're requesting of us because you want to do some sort of restorative since this particular patient is missing a premolar. So you start to look at these tools a little better, and we get to actually use the Propel outlining of, okay, I'm going to have to do the anterior upper arch, at least 1 or 2 perforations, minimum of 2. In the attached gingiva, we discussed in the second webinar of where I like to put the Propel perforations, and typically I like it on the attached gingiva. I don't like to go too far in the areas of vestibular area. That typically gets the patient to bleed. I don't like them to see blood. So what other movements can I identify? Well, occlusal views, you can take a look at an occlusal view. That doesn't tell me much. I don't know exactly how much movement there is. Yeah, I see a lot of crowding and a little bit of overlapping. You can use the grid feature, deactivate your C chain. So those doctors, the last 3 aligners has the little brown tab on there. Those last 3 are 3 additional aligners that are given to tighten any interproximal opening. The problem with that is that it decreases your amount of IPR, which is no problem, but it doesn't show you a true movement. You're short a millimeter. I'll explain what that means in a minute. First, you have to go on your overcorrection where it has a little plus and deactivate that. You have to get rid of those extra 3 aligners when you're looking at what tooth are movements. Because when you start to count in the grid feature, when you have the C chain activated, what happens? Have you seen when the ClinCheck goes forward and then you start to lingualize back and it just kind of jumps and it tightens those areas interproximally? That's the actual virtual C chain or overcorrection aligners. We're going to do a live ClinCheck this particular case, and I'll show you what I mean. But if you count the millimeters, that's 1, 2, 3, 4 millimeters of movement. As soon as you deactivate the C chain and you get rid of that overcorrection, guess what happens? Now you got rid of your extra 3 aligners, but look at when you count 1, 2, 3, 4, now 5 millimeters of movement. So you actually have 5 millimeters of movement of true movement. Again, ideally, the lower arch would also need to be propelled at least canine to canine. Now, I've put the mesials of the premolars, and I'll discuss that in a minute. But if you look at the most important area right now is between tooth number 23, 24, 25, and 26, most importantly. Those teeth need some sort of a inflammatory process, cytokine activity, or the bone not to be so dense. Now, going back to your tool feature, you can also activate your tooth movement tab. This will now tell you the actual amount of millimeters of tooth movements for each tooth, from tooth number 1 to tooth number 16 on your upper arch and 1732 on the lower arch. By doing this, you can actually see where it's in bold of where the tooth movements. Now, those of you who've heard my lectures before, I talk about what I call the Ataii 246 rule, which means that if you are moving teeth greater than 4 millimeters, buccal or lingual on anterior teeth, meaning given you have enough bone, and on the buccal tooth number 8, you're proclining forward or lingualizing back greater than 4 millimeters, those are considered more of a difficult movement. If you're extruding greater than 2 millimeters, it's considered a difficult movement. And in this particular case, the 246 rule, extrusion greater than 2, and correcting deep bite or overjets greater than 4 millimeters, this tooth fits into the extrusive that's about 3.1 on tooth number 9. You can see on the lower part of the arch, on the lower part of your screen, that the extrusion is greater than what the aligners can give you, as well as the rotations are 25 millimeters on that tooth number 8, which is a little bit greater rotation. 15 degrees is predictable. That it's 25 degrees what we're asking for. I've put up my 2-4-6 rule as well as the rotations on the Ataii site for you to go through. Align also has it as setting as their default. But simply said, when you look very closely, counting the grids, because now I'm using the superimpose, the grid feature, as well as the tooth movements, and when you start to count from the incisal of each lateral and central incisor to how much movements we need, and as you count these grids, anywhere between 4 to 5 millimeters. So I know that I just mentioned the overjet 4 millimeters is really pushing the envelope. It's predictable, but it's pushing the envelope. That's where now I can utilize this tooth movement table and notice that each one of these teeth are going to be difficult movements. Again, we're just planning ahead, and I always like to increase the size of these teeth. I don't know if those of you who know, you can actually use the tab, make the teeth size bigger so you can look at it on your 1 millimeter grid form, and you can simply see that extrusions, rotations, and the amount of distalization and opening of the space that I need between tooth number 12 and missing 13 is going to be also more advanced. So all these areas would require some sort of a perforation, again, using the Propel treatment. So this is the case we were discussing. So we're going to look at it a little bit closer now. And the patient is a class 3. I'll show you the upper and lower arch. He's got he's got the bicuspid that's missing, and the upper and lower arch definitely don't fit right. I would consider this an 8 out of 10 as far as degree of difficulty. But my plan is to spend a few minutes in a treatment mapping the plan for the ClinCheck. We're going to go through and doing this. We're going to give the patient, as I say in my first treatment, we're going to put jackets on your teeth. Those are the attachments. We're going to put your teeth on a diet. That's the IPR. Your teeth have been fat for too long. That's interproximation, as I mentioned. And we're going to wake up your bone. That's the Propel. So that first visit, I like to put on the attachments, do the IPR, and do the Propel and get it done with. So I deliver the attachments, do the Propel that first visit, see the patient back after, and hand them about 5 or 6 aligners. Typically in my office, we hand them 6 aligners, 5-day intervals. They come back in 6 weeks, and I usually tell patients that's when you start to refer me a patient, because you see your teeth are completely moving. And we've created the interproximation. We check the aligner fit. We make sure the IPR has been done. And then we bring them back on that second visit, and we hand them another set of aligners. In this particular case, I usually see the patients every 6 weeks. We don't need to do another set of Propel or another set of perforations and until we're done. So typically by my 4th visit, I'm taking off attachments and doing some fine tuning if needed and go into retention or stabilization mode. That's typically how most of my patients are done in these 4, maximum 5 visits in these crowding and spacing type cases. So in Sam's case, when he came to my practice, we knew that he's got the crowding, he's got the anteriors that are in crossbite, tooth number 10, and this is exactly the case you saw with the missing premolar. And our agenda is to give him a nice U-shaped arch, is to eventually set him up for better aesthetics as well as some sort of restorative. But we want to get the crossbite out of the way. We want to get some of the posterior teeth that are collapsed fixed, in getting that arch rounded out on the upper arch as well as the lower arch. So we placed the attachments, the photos were taken. Here's what the Propel looks like. Those of you who haven't seen on the attached, when I say I want to put the attached gingiva, that's right after the Propel was done. So you can kind of see on the distal of the premolar, or if you will, mesial of number 3, as well as all the way around to number 12 and the missing area of 13. We propelled anywhere between 2 to 1. On the lower arch, it's a little bit harder to get 2 in, but I knew that 23 to 26 are a little difficult, so we try to put in 2 sites of Propel. And that's pretty much what I give the patients. They rinse out and finish the IPR and hand them the aligner, and I send them home. So you can clearly see where what we call it looks like bee stings, if you will. And we sent him for 6 weeks. Bring him back with some IPR. He changes the aligners. In the initial phase, I decided not to have any upper movements, and the reason was I wanted the lowers to kind of start moving. I always look at these cases from an overjet view, and I say that to your doctors because I want to get that crossbite resolved, but I want to start lingualizing and kind of proclining the lower arch, and then before I start lingualizing the upper arch. So I had a passive aligner intentionally added on the upper one. That's just the way I did my ClinCheck for this particular case. We'll see it. And by aligner 10, I should see that the lateral on number 10 is starting to come out, and we're starting to correct the crossbite. So this is a good chairside tracking to look from an overjet view and make sure that when is that crossbite completely jumping? Well, by aligner 16, I'm getting it edge to edge. This is where the patients start to talk about when I eat, it feels like fingernails to a chalkboard, right? Because the upper and lower teeth are kind of banging against each other as they're jumping that crossbite, especially anteriorly. So by aligner 16, I had already gone in and telling the patient at the very first visit, by aligner 16, when these two teeth are going to go cross past each other, when you go to eat something, your teeth are going to bang against each other. So be careful when you go eat, or leave your aligner on when you want to eat. Have some soft foods. Don't go in opening paper or Ziploc bags or anything like that, tearing it with your teeth, right? And if you can see those front teeth, the reason why they have that, he has a chipping on number 9 and the lateral, the incisor on the lower, is because of sunflower seeds. He was a heavy sunflower seed eater, and those are just sunflower seeds that are just buried in us. So you cannot be eating sunflower seeds during aligner treatment. I'm going to get unwanted intrusion or teeth going in. And that's why I put those attachments to pull them out of your bone, not push them in. So it's a very hard habit for them to break in not eating the sunflower seeds. Another tool I'm going to give you in the view section, right on your ClinCheck Pro, you can actually now have your dual side-by-side view, which will show you the initial where the patient was and where the patient is at the current time you see him, whether they're on stage 1, stage 10, stage 16, and you get to kind of see side by side and reminding the patient where they were, where they're heading to, and make sure at least you're on track so long as the aligners are fitting. So in this particular case, when I saw him on aligner 16, I saw the extrusions are not working out too well for me, but it's tracking better than me not having the Propel done. It's tracking really nicely, except tooth number 10, not too happy with, but I could maybe use an aligner seeder of some sort, or maybe a chewy or some sort of a vibration to get the aligners to seat a little better, but I didn't need to do another set of Propel on him. One was enough. He's tracking beautifully. Just as long as I IPR, and even the ClinCheck at 16, stage 16, that's what he looked like at stage 16, exactly where the chair side was, except the lateral on number 10. I'm having a little bit of tracking as far as extrusions. That's okay. I can catch that up at a later point, or maybe throw some bonding. He's already got some chipping anyway. So as we start to see the tracking without the aligners on, you get to kind of look and see where the patient has been very compliant, changing the trays, but number 10 was bothering me. So we're going to see this case as how we can make sure the posterior bite lands. And some of you doctors might see that patients are not wearing them when you're telling them 2 weeks at a time versus you tell them only 5 days. 5 days at a time, they have a much better time. Everything's cleaner, and they just remind themselves to change it once a week rather than every 2 week time. And as you start to see his case, I like to check the lower crowding is getting better. The upper arch is getting rounded out. So I'm not going to stop and add more Propel or go into a refinement. Everything's tracking fine but one tooth, not a problem. By stage 19, I should have the crossbite corrected, and the lateral should be overlapping completely over the lower arch. So, this is where I want to do my bite setting and final occlusion. And at that point, at stage 19, I did do another scan of him. In some of you doctors who don't have a scan or maybe an impression, and the ClinCheck came back as adding a little bit of IPR to lingualize that lower arch so I can have a better anterior coupling. Again, something that I don't need to do more Propel on. So I tracked beautifully in 6 months, a case that was going to take a little bit over a year. And now I'm just going to go into bite stabilization, make sure everything's landing okay, get the posterior line to start working on some restorative. You can see I added some bondings on the chip teeth on 9 and 10. And I always like to do some little bondings before we finish up the final case. So in this particular case, I've got to lingualize the lower arch and kind of stabilize him. But not bad for moving in 6 months of movement. So what I like to do now is kind of go live to his actual ClinCheck. And those of you doctors who are looking at this, you can kind of see the ClinCheck from an anterior view. When you first look at him, I know it's tempting to press this play button. I know it's tempting to look at everything. Oh, well, how is this? How does it look? Oh, it looks like a beautiful cartoon. That's the way I want to have it. Well, what I want to do is see whether or not this is predictable. So first thing we're going to do is I'm going to look at it from an overjet anterior view. What is it going to look like from an anterior coupling? Then I want to look at it from an overjet side view, left and right buccal. So when you look at this particular case, remember what I mentioned to you is you can actually take in your tool setting and have it where you're getting these patients, and you can actually have your tool set up so that you can see all the movements. So in the treatment section, you can see it, and I'm going to just move this screen down for you guys to kind of, so I can share my screen fully for you. Okay, so you can see right here in my tool setting, I can now go where I can see the tooth movement difficulties. So I'm sure you all saw where I can see that. And once you hover over it, it's going to tell me, look, the extrusion is about 3 millimeters. The extrusion is greater than the 1 or 2 millimeters that is predictable for a lateral or incisor. So we knew that that was coming ahead of time. It's a little more difficult for us. And you can kind of see in this particular case, my what I like the tooth movement table. What I just showed you, one by one, you can actually go through your mandibular arch, and it'll tell you which teeth are the translation movements, the rotational movements, and actually some of them are in bold. So we can clearly see on tooth number 25, you've got 26 millimeter of rotational movement, which is a little bit more difficult. And again, you're going to need some sort of auxiliary. In my case, I like to use the Propel as my auxiliary. Okay, so when you start to look at these cases, this tool setting really helps you in using the different setups. Now, let's go ahead and put this together and start from the very beginning. So I'm going to go ahead and take these tools off for you, so that way you can kind of see where we start, and we'll move one by one with these patients, okay? All right, so let's go ahead and get started with an overjet view. Looking at the overjet view, I want to go to the final stage. In my final stage, what I see here is a couple of things. I'm not too happy with my canine, nor am I too happy with my lower lateral, canine tooth number 22 and lateral. It's too tight. I believe I need to finish in maybe 1 to 1.5 millimeter overjet overbite. So the first thing I'm going to tell them is, hey, I like to finish in a 1.5 millimeter overjet overbite, which might potentially add some lower IPR for me. That's okay. I know now that I'm going to need Propel, or at least some sort of perforation from canine to canine. So why not expand the arch and make the upper arch a little better as well? So once I look at the overjet view that I want to finish in that 1.5 millimeter overjet overbite, since that's a very tight anterior coupling, not enough room for 2 pieces of aligners, then I'm going to now look at the maxillary view, and you can now turn your grid button on and just go to the final stage, and that's where I put the grid and the superimpose together, and you can simply count each little box of your grid feature. You can count that there's 1, 2, 3, 4, 5 millimeters of movement on that lateral, and we know at least 4 is pushing the envelope. So I'm going to now, by expanding the arch, at least help in reducing some additional cross bites that could happen, and you can't do one without the other. So definitely we're going to need some Propel, some sort of from premolar forward. As you can see, most of my movements are premolar forward, not much movements in the molar section. Okay, in this particular side, you can see that I don't have much movement on my molars, other than maybe a simple little, I don't know, millimeter or so, and that's it. So you have no more than, if you count the grids on that molar, so we have 1, 2 millimeters. That's fine. So I'm going to give some Propel on the mesial of this number 3, but I don't need any on number 14. So to put it in clear verbiage for you, anywhere that I see greater than 2 millimeters of, or 3 millimeters of movements, I know that that's an area that I want to go ahead and do perforation, typically from premolar, maybe first molar. I very seldom do second molar perforations, unless if the patient's missing a bicuspid. Okay, so we've now kind of addressed the idea of the grid feature and superimpose. I want to talk a little bit about what we talked about, the C chain or the overcorrection. So in the overcorrections, as you see on the bottom of your screen, when I press and light that up, you can see the little brown kind of pop up. So you're giving more aligners or less. But what I want to show you is, look what happens when the overcorrection is put on. And as you start to move your teeth, that very final stage, you kind of see that little lingualization that happens. That is where you see the reduction in your grid feature. So that's the area where as everything proclines forward, and as you start to lingualize back, keeping the overcorrection on, you get an extra millimeter reduction back. So when you put the superimpose, you're not getting a true accurate measure of the movement. So that's why I like to let go of the overcorrection, and that's the amount of movement I really need. So I usually tell doctors, you know, the overcorrection is great if you over IPR and you can close those interproximal contacts, but it gives you an extra millimeter of movement that you may or may not need. It's a great consideration for you to make when you're seeing where you want to perforate. And again, in this particular case, I'm going to go premolar to premolar regardless, because I'm still doing some movements. Not much, but if you can see that first molar, there is some movements on tooth number 30. So definitely I want to do mesial of number 30. And sometimes I hit the actual distal as well, but in this case, I ended up just doing 2 perforations right here on the mesial of 30. Okay, so going back to the ClinCheck, when I look at the overjet view and I make some changes in having the discussion of finishing in a 1.5 or 1 millimeter overjet overbite, and we can kind of go through. I don't know, some of you who read the comments, it's always ideal to read the comments, but you can actually see in your staging where it also shows that each aligner, where as your staging is going through, where some of the difficult movements may be. So I typically like to read the treatment sheet. It's just easier. You just scroll down and see which ones are the advanced movements and which ones are the moderate movements. But some doctors like to actually go with the staging. It's harder to utilize that than me just going on the toolbar, as I showed you earlier, in seeing and utilizing the tools that are having for me and checking the difficulty as well as the actual tooth movement table, so you can actually go through tooth by tooth, arch by arch, and understanding where the difficult movements are, using the superimpose, and you can actually count it on your own if you like, but it's already been done for you here in terms of rotationals, angulations, inclinations, and you get to review it. Okay, so let's go ahead and talk one final view that I like, and that was the occlusion that we discussed. So I'm going to get rid of all these other tool settings for us, so that way we can discuss the right here where it says occlusals. So those doctors who are using this particular format, I love the occlusal view, because from the area where you start, and let me move this up again. Okay, from the area where you start, you can just go up from zero aligner. As you start to move forward, you can start to see where the teeth start to turn green and where they start to occlude and where they start to hit. And in some cases, you actually see red. In some cases, you actually see that the ClinCheck software will show you red heavy spots. And those are areas that you may sometimes have to either check into your occlusion, that you may have to do some spot occlusion, or you have to pay close attention, because as you start to move these teeth, and you get to see this translucent color teeth, but you start to notice that the occlusion, which teeth are actually hitting. So I really like this feature because cusp to fossa, I want to make sure that as I expand, I get that cusp to fossa feature. And those of you doctors who sometimes see red light up, red, that's when you start to get the posterior open bites, because the software is telling you it's hitting heavy on the anterior, and then the posterior you have no green, means you have a it's going to happen where you end up with a posterior open bite. So a lot of times doctors don't know about this occlusal button yet, and you're making the bone nice to work towards your side. You're doing the propel, you're doing the accelerated movements, but you start getting the anterior coupling that's very heavy, and you start to get the posterior open bite. By adding more propel, that doesn't help you. You have to resolve those heavy contacts, get those out of the way, and then maybe if you want to go ahead and reinduce propel one more time on the second round, that might help you. So I like to kind of always review my occlusal contact points. You can also see it from the inside, from the back of the patient's head, as we talked about earlier. You can kind of see where these teeth are hitting, and is that a good bite to fossa for you? And again, I would like to see this lingualized a little bit more, and I think I redid my ClinCheck to reflect that, to add some 0.2 IPR on the lower arch to kind of get that upper arch to finish in a 1.5 millimeter overjet overbite to get better anterior coupling. Okay, so in showing that, I'm going to now jump back to our, and I know some of you will have some questions, so I'm going to leave some questions for you at the end for us to answer. So kind of giving you the ClinCheck tools, where to perforate. I always like to talk a little bit about how do I generate referrals? I'm glad you showed me all this, Dr. Ataii, but there's some additional tools that I always like to talk about. Generating new referrals for me is always part of a conversation with the patients. Look, in 6 weeks, you're going to see your teeth move. I'm going to need you to send me a patient if you're happy with us. So some of the things that I like, I know some of you doctors kind of use the ClinCheck software to show the patients what a great teeth they're going to look like they have. You don't collect the deposit, you don't collect the money, and then you throw an extra $500 at them if they want to move their teeth faster. It just doesn't work that way. So in my office, I very seldom do I take the impression or take the scan, do the ClinCheck, and then go and try to get these patients into treatment. No. What I do is once we collect the deposit and we talk about Propel's part of our system, it is true that you will finish a little bit sooner, but it's not necessarily about finishing sooner, but staying on track. And by the time your friend who's doing Invisalign at another office is on her second or third refinement, we're already done with you. You've already got your teeth whitened. You're well on your way for a better smile while they're still struggling to finish. That's some of the ways that the conversation piece. So while they're manufacturing the aligners at the ClinCheck, I simply share the ClinCheck with my patients with simply pressing the share button, putting in a quick little $500 off accelerated 3D ortho for your referral or for your next patient putting in, or a lot of times patients have already paid the $500 included in their treatment plan. We give them a credit of $500. I know it doesn't make sense to you doctors, but understand, if a patient's going to give you the treatment and trust you, and you give them a credit of $500, and in some cases, I know some of the offices are billing and getting paid from the insurance company for the Propel and osteoperforation treatment. In my office, it's going to cost me a lot more than $500 to advertise for a new patient. And I'm giving them credit of some sort. They're going to be spending it on a filling or on a veneer or bonding. So, but whatever promo you want to write, you don't have to necessarily write that. You can write down, extra bleaching or retainers or whatever you like. You can put a message in the comments section and email it to the patient. And that's very simple. You can put a referral $500 off. You can do whatever you want. And courtesy of Dr. XYZ, I know Dr. Slayer is in Arizona. Or I think he's in DC. I'm not sure. He sent this out to his patients, and I loved it. I thought it was great. That just simply says, "Hey, man, you refer a patient, we'll be more than happy to get you an extra, some sort of a credit towards your treatment." Now, again, we have to be careful that we're not incentivizing the patients. That's why they've already paid it. And at that point, I kind of give them a credit. So check with your dental board with those types of scenarios so you're not incentivizing or giving some sort of kickback to your patients. But it's a great way of also using the ClinCheck software to generate aligner schedules. So since you're actually telling the patient to change every 5 days, you can just have a finish date, input it, and simply said right there on the generate aligner schedule, you print out when they change every aligner. They know when to change every aligner. If it's 18 aligners, 14 days is going to take you 36 weeks. Well, we're not doing 14-day changes. We're only doing what? 5 or 7-day changes. Okay, fantastic. 7-day change, that's 18 weeks. Guess what? That's as low as $39 a day that you can, or $40 a day that you're going to be done in 18 weeks. So, it just kind of breaks down for you, some of your doctors, to understand that you're going to get paid in whichever way. I use this as a tool so that way patients not only understand that, hey, $40, it's worth it, and you're going to get paid within 3 or 4 months, no problem. So it's another way of kind of giving my patients an option and help the process of getting my patients into treatment as well as follow-up treatment. So I wanted to give you a couple of these tools, and those of you who couldn't hear me, it was right there on the doctor's section where you actually can do the ClinCheck, and you can actually go generate a liner schedule, and you can simply have the schedule printed out. If it's 5-day or 7-day, you just put in the finish date, and it'll just break it down for you, and you can put costs to it so as to how much it costs them every day, if you will, or every week. Okay, so I know I always leave a few 15 minutes or so for questions and some Q&A. So there's a lot of material that I covered, so I wanted to see if there's any questions from the audience. And I've had a couple of doctors ask me a couple of questions. One of it was about the ClinCheck again, so I can go back and review that. But as you type in your questions, let me answer one of the questions that was asked about this feature. And if you recall, you turn that on where you put the occlusals. So you can just show your occlusal, and you can see in whichever direction and at whatever stage. So you can have it on stage 1. You can kind of see how your occlusion lands, and as you play stage 2, 10, and as you go forward all the way to the final staging. And the final staging is where I like to see where my occlusion is landing. So that was right here on the occlusal tab that I turned on. Okay, so let's see. Can you quickly go over C chains? Yes. So I can go over C chains. Dr. Chin, I think it is. So the C chain is right here. It's called overcorrections. So it's a little plus. You can kind of turn it on or off, and you can see how I add those extra 3 aligners. And what the C chain is, these are overcorrection aligners. So let's say you over IPR'd an area, or some teeth are moving and there's some spaces interproximally. If there are interproximal contacts, those extra 3 aligners are geared to tighten the contacts from upper and lower arch. So those extra 3 aligners have an extra 0.25 millimeter of torque built into them, just like how doctors sometimes put that little C chain. It looks like a fishnet on your teens or on your patient's teeth on wire brackets. This does the same thing. It tightens the open interproximal or light interproximal contacts. The reason why I want to take this off is because it doesn't give me an accurate reading of how much movement I have to put on. So when I put the grid feature on, the superimpose, if you can kind of look at this, where we're kind of looking at, checking without the C chain, okay? So I'm going to turn the C chain on, and I'm going to press the play button. So you go out, and as soon as you turn the C chain, and see how everything kind of tucks back in. That's the extra tightening. So when you take the C chain off, the teeth are landing a little more buccal. And you turn it on, they tend, and I got to press the video for you. Everything tightens in. You see that? Everything tightens in. So that extra overcorrection is tightening and over tightening. And I hope that made sense. Okay. How much do you charge for the Propel, and how do you talk to patients about the Propel? Okay, so the way I do my charges on the Propel typically is an extra $500 charge for the entire mouth, upper and lower arch. So in the last webinar, in webinar 2, if you recall, I had put the pricing structure, and that you're going to have to go back to webinar 2, or you can go on my Ataii.com site, that's ATAII.com, and download how I actually tell the patient you're level 1 or level 2. Level 1 for me is 6 millimeters of crowding or less. Level 2 is 6 millimeters of crowding or more. So I add an extra $500 for those advanced type movements. And anytime that you guys hear the 2-4-6 rule that I talk about is typically the amount of crowding or spacing the patient has. So I don't base it on time. I don't say your case is a year, 2 years, 3 years, 10 years. It's based on the amount of crowding and spacing. Either way, it's going to take me a little bit of more auxiliaries to do the work on, and Propel's $500. I also put some codes there and some doctors that have success in billing some insurance codes. So I'm going to have to defer you back to that the second webinar that we had. Or you can go on Ataii.com to download under Propel. Just in the little search button, put in Propel, and all the information and past webinars will pop up for you. How to use bite ramps to correct cross bites. So now we're talking a little bit more about ClinCheck. So as far as the bite ramps go, I'm just going to give you a quick little 2-second dissertation about it. You know, we have the G5 series that has the lingual bite tabs, and what that does is that it discludes and I'll get rid of the grid feature here. It discludes the anteriors by kind of intruding and correcting curvus V. Lingual bite ramps are typically put on patients that have a deep bite. So in this case, this patient doesn't really have a deep bite. He has no real bite. So lingual bite ramp isn't going to work for him. But it's a G5 feature, and you should ask for it when there's a deep bite. So picture if this upper incisor was all the way over the lower arch. That's when you would ask for a lingual bite ramp. Okay, thank you on that. Prior to perforations, you are using topical or infiltrating. If topical, are you getting this at a compounding pharmacy? What topical are you using? Does this have to be prescribed for the specific patient? Yes. So my first webinar was discussing about infiltrating or topical. Currently, you can order from a pharmacy, and some of your Propel representatives have them. There's one in Florida, there's one in California, one Midwest. That is a perlicaine, tetracaine, and these are profound topicals, 30%, 10%, 20% by prescription, that you can actually put the profound topical and it works just fine. And if you recall, I kind of showed you the video of my kind of using that infiltration. I'll go back to that little video. So the top video that I'm going to show you, this one here was with topical only, without infiltration. So that's just with the profound topicals, because I only really did 2 or 3 sites. But if you're going to use the entire Propel device, you might as well just use the entire you might as well put any premolar to premolar section, because you're throwing away that piece. This right here, the power driver, is with a infiltration, just basic infiltration of lidocaine, and that's what I used for her on the lower of the screen, because I had to go 3 millimeters, and I did some a little bit more deeper on the molars. I haven't gone beyond 5 millimeters yet. So as soon as I feel the bone, and those doctors who are kind of used to doing this, you kind of, as soon as you feel the bone, kind of like drilling into a drywall, and you hit the wall, the wood in the back, that's exactly what this feels like. You're kind of twisting in. As soon as you hit that bone, you twist a little more and come right back. All you want is a small, tiny little bit of microfracture, and I call that micro delicately, because really we don't know how much is micro or macro, but it's small enough where, as you see on the screen, looks like a little bee sting. I want to create that cytokine, that inflammatory process, so the osteocytes start proliferating, and we start to go towards a little bit more accelerated cellular activity, so I can get the momentum and tooth moved faster with each aligner. And I put it in layman's terms to my patients. Say, look, it's like moving teeth in mud rather than concrete. But your bone will get hard again, because after about 4 or 5 months, the bone starts to get solid and the body starts to heal itself. That's pretty much the conversation I have with my patients. Okay, so let's see if there's another question. How did you use the bite ramp? Okay, since the wearing of 2 pieces of plastic generally leads to posterior open bite, does it make sense to finish the ClinCheck with red occlusal contacts on the posterior teeth? Which yeah, okay. So the question that they're asking, very intuitive, is saying, since we end up sometimes getting the anterior. So let me read the question exactly. Since wearing the 2 pieces of plastic generally leads to posterior open bite. So remember, wearing the two pieces of plastic generally does not lead to posterior open bite. But if you hit heavy anteriorly, then yes, you'll get a posterior open bite. So take a look here. As you go through, and I'm going to just show you where this could potentially be a problem. So look at the crossbite as we kind of start to lingualize. If I don't pay attention, and right here where my lateral, tooth number 23, is hitting against tooth number 9. If I don't pay attention and there's not enough space here between interproximal contact points and they start to rub, I can get a posterior open bite. The posterior starts to lift because the anterior has the plastic, as you mentioned earlier, doctor, and it's kind of lifting. So yeah, you can always finish in your occlusal tabs and contacts in red posterior and green anterior. But understand that may mean a lot of IPR on your anterior. So if you tell them always finish in a light anterior contact, they may always give you lower IPR that could sometimes be up to 0.5. So not all doctors like to do that much IPR. So that's why I like to use the verbiage, please finish in a 1.5 millimeter overbite over jet anterior coupling. So then at that point, it's okay to have a little bit of IPR, but not much. I'm kind of quantifying the amount of interproximation so that it, for them, so that way they know that, okay, they're going to finish in 1.5 overjet overbite. Then I get to see how much IPR they gave me. If they gave me 0.5, I say, you know what? Heck with it. Finish it in less. So I don't think you can make always standardizing saying, look, I want to have heavy posterior so that way on my occlusal bite tab, it's always red in the back and green in the front. I would just say, I would use the verbiage, please finish in a 1 to 1.5 millimeter overjet overbite. Then you get to see how much IPR you have. Okay? I see that our time is kind of up. You guys have a lot of questions coming through. So until I don't know if we're going to have a third webinar, but it sounds like we may with the amount of questions that's been generated. But for now, I lead you over to Ataii.com site, as well as your Propel rep. Under the search button, you can go under Propel. Any additional questions, I put my email up there for you. I can help you, and I hope to see you next time, doctors. I am trying to recover from a cold, so I apologize as I'm kind of sniffling through it, but I think we got through it, so I appreciate your patience. Until next time, I will talk to all of you and see you all on the hopefully upcoming 4th webinar. Thank you, and I'm Dr. Ataii.